Hello, everybody. My name is Hunter King, and I'm a third-year school psychology doctoral student at the University of Utah in Dr. Aaron Fisher's UTech laboratory. Some colleagues and I trained a caregiver through telehealth on the delivery of a home-based behavioral feeding treatment for an adolescent Hispanic male who had a long history of selective and avoidant feeding behaviors. Through the referral process at our pediatric feeding clinic here on campus, the adolescent did meet DSM-5 criteria for avoidant restrictive food intake disorder. We trained the caregiver through Zoom on how to implement differential reinforcement of alternative behavior, as well as a contingency management procedure in which the adolescent would receive small amounts of money to help reinforce consumption of these novel foods, which you can see in Figure 5 in terms of how much money each bite resulted in. Treatment was fairly effective, very effective for bananas and water. Not quite as effective for green beans, but when we did introduce carrots and cantaloupe, we saw that there was very impressive levels of consumption towards the last 6 or 7 sessions of this treatment. With regard to water, very effective. The adolescent had a history of drinking chocolate milk and Propel water. But overall, fairly effective intervention. There's still a whole lot to be determined in terms of the best practices for treating AirFid, given the recency of its recognition in the DSM-5. However, right now, as we're seeing a surge in telehealth and teleconsultation studies, hopefully much more will be revealed in terms of supporting people who might find it difficult to receive treatment in person in clinics. And so with that, hopefully the future of AirFid research is explored through telehealth so we can support this population.